So if you get like a bacterial infection, right, the doctor writes a prescription for an antibiotic, and the instructions are they're incredibly clean.
Oh, yeah, totally. Take one pill twice a day, 10 days, and you're done.
Exactly. You follow the recipe, you finish the bottle, and that's it. There is a total comforting precision to it.
Right.
But, and this is what we are getting into today, if you step into the world of menopausal hormone therapy, specifically treating severe vaginal atrophy, that precise instruction manual gets completely thrown out the window.
It really does. It's wild.
Yeah, so if you're one of the millions of women dealing with this, you might pick up your medication, read the printed label in the box, and find that it directly contradicts what your doctor just told you to do in the clinic.
Which is an absolute maze for patients. I mean, you have a condition that is clinically known as genitourinary syndrome of menopause, or GSM.
Right, GSM?
And it causes severe dryness, excruciating pain during intercourse, recurrent urinary tract infections. It fundamentally alters a person's quality of life.
It's devastating for so many.
Yeah. Yet, when it comes time to actually initiate the treatment, the instructions are just this chaotic mix of legacy guidelines, off-label prescribing, and, frankly, sheer guesswork for the patient.
And that contradiction is exactly what we are sorting through in this deep dive. Welcome in, by the way. We are so glad you're joining us today.
Absolutely.
Because our mission today is to unpack the specific, highly localized protocols for the loading dose of vaginal estrogen therapy.
And we have some really solid sources to help us do that.
We do. We're looking at a huge stack of sources today. We've got the latest guidelines from the American Urological Association, treatment pathways from the UK's National Health Service, official FDA prescribing labels from pharmaceutical giants like Pfizer, and honestly, my favorite part, real-world patient questions from Reddit.
Those are always so telling.
Right, because we need to see how this actually plays out in people's bathrooms, not just in a textbook. And the core mystery here is why the loading schedule, that crucial period when you first start the medication, why it varies so wildly depending on the product, the active ingredient, and the actual severity of the atrophy.
Well, to understand the chaos of the schedules, we really have to start with the tissue itself.
Okay, let's unpack this.
Yeah, before we get into dosages and days of the week, we have to look at the underlying physiology. Like, why do doctors prescribe a massive initial flood of hormones, the loading dose, instead of just putting a patient on a low, steady maintenance dose from day one?
I was wondering that myself.
Yeah.
So what is physically happening to the vaginal tissue in severe GSM that requires this, aggressive initial chemical flood?
We are looking at tissue that is in a state of absolute starvation.
Starvation, wow.
Yeah. A healthy, well-estrogenized vagina has a slightly acidic pH, usually between 3.5 and 5.0, and that acidity keeps infections at bay.
Right, which prevents the UTIs.
Exactly. The tissue itself is thick, it's highly elastic, it's well lubricated. It has these deep folds called rugae, which act almost like an accordion.
Oh, like allowing the tissue to stretch and expand comfortably?
Yes, but when estrogen plummets post-menopause, that accordion just flattens out. The rugae disappear entirely. The pH elevates above 5.5, which is why those UTIs just keep coming back.
Oh, that sounds awful.
It is. The mucosal lining becomes incredibly thin, fragile, and just bone dry.
You know, I always picture it like a desperately parched, potted plant that you forgot to water for a month.
That's a great visual.
Yeah, so the soil is all cracked, right? And when you finally take a pitcher and pour water in, the water vanishes immediately. It's absorbed so aggressively.
Right.
But if you keep watering it over a few weeks, the soil expands, it's rich again, and it becomes saturated. At that point, if you pour that same amount of water, it just pools on top.
Because it can't take anymore.
Exactly. The absorption rate slows down because the environment is already healthy. Is that basically what's happening with the estrogen?
I see where you're going with the absorption speed, but soil is just acting as a passive sponge, right?
Oh, sure.
Human tissue is much smarter and much more active than that. It isn't just about the tissue getting chemically saturated. What's fascinating here is what's actually happening on a cellular level.
Okay, lay it on me.
Vaginal epithelial absorption is actually at its absolute peak when the tissue is at its thinnest and most atrophic.
Because there's no barrier.
Exactly. Because the physical barrier of the cells is so compromised, the estrogen you applied during that first week is absorbed incredibly rapidly into the surrounding local tissue, and crucially, a bit of it actually leaks systemically into the bloodstream.
Wait, really? Because the wall is literally too thin to keep the hormone localized.
Yes, exactly. But here is where the magic happens. As that estrogen triggers cellular mitosis.
Meaning the cells start dividing?
Right. As the cells divide and the mucosal layers literally rebuild themselves over the course of a couple of weeks, the tissue builds a new biological shield.
Oh.
The newly plump, healthy superficial cells create a physical barrier. So as the tissue heals, systemic absorption plummets.
That is fascinating. So the healing process itself acts as a barricade to keep the medicine from going too far.
It does. And that physiological mechanism dictates the entire medical strategy.
Which explains the loading phase.
Precisely. You flood the tissue when it's thin to wake up the cellular machinery, and once the tissue thickens and creates that barrier, you drastically drop the dosage down to a maintenance level.
Because you don't need a flood anymore.
Right, you just need a trickle to maintain the structural integrity that the loading phase built up.
That makes total sense. Which brings us to the actual protocols. Because I want to know, if I go to the pharmacy and pick up one of these medications, what is the clinical consensus for that initial loading flood?
Right, the practical application.
Yeah, because looking through the American Urological Association guidelines and the NHS pathways from our sources, it seems like most of them follow what we can call the rule of two.
Yeah, the rule of two is really the bedrock of modern clinical consensus for most localized estradiol products.
Okay, so how does that work?
So if you are using estradiol tablets like Vagifem or Uvifem, which are these tiny 10 microgram pills you insert, or if you are using soft gel inserts like Invexi, which come in 410 micrograms.
Or even creams, right.
Exactly. Even if you are using estradiol creams like Estrus, the standard clinical protocol is pretty universal. You apply the medication every single day for the first 2 weeks, and then you drop down to a maintenance dose of twice a week.
2 weeks daily, then 2 times a week. That is clean. I like that. That makes sense.
It does.
But and here's where it gets really interesting. The sources reveal a massive problem, and I was genuinely confused reading this.
The labels.
Yes, the rule of two is not what is printed on the FDA prescribing labels inside the actual box you take home.
No, it is often wildly different. And I can tell you, this is the primary source of anxiety for patients. They hear one thing in the exam room, and then they go home and read something terrifying on the pharmacy insert.
Okay, let's use estrus cream as the prime example here. Because the AUA guidelines say the doctor should prescribe a starting dose of 0.5 to 1 gram of cream daily for the loading phase.
Right, a very small amount.
But the official FDA label printed by the manufacturer says patients can use 2 to 4 grams of cream daily for 1 to 2 weeks.
It's a huge discrepancy.
4 grams of estrogen cream is a massive volume compared to 0.5 grams. Why on earth would the official label contradict the modern medical consensus?
Well, it really comes down to medical bureaucracy and, honestly, the era in which these drugs were originally tested.
Oh, like they're just old.
Yeah. When legacy creams like Estrus were moving through clinical trials decades ago, researchers tested higher volumes, like those 4 grams. They proved it was safe and effective at that dose back then, so the FDA approved the label based on that specific historical trial data.
But medical science has obviously evolved since then.
Significantly. I mean, modern clinical practice operates on the principle of the lowest effective dose.
Which makes sense for any drug.
Exactly. Doctors realized over the years that 4 grams of cream is incredibly messy, it's uncomfortable, and it unnecessarily increases the risk of estrogen leaking into the systemic bloodstream.
So they dropped it.
Yeah, they found that 0.5 to 1 gram is highly effective for almost all women to achieve that local healing.
So why doesn't the pharmaceutical company just, update the label? It's just a piece of paper.
Because changing an FDA label isn't just changing a Word document. It often requires the manufacturer to run entirely new, multi-million-dollar clinical trials to officially prove the efficacy of the new lower dose to the FDA.
Oh, wow.
And pharmaceutical companies have zero financial incentive to spend millions of dollars just to update a piece of paper that recommends you buy less of their product.
That is wild.
Isn't it? So the label stays frozen in the past, and modern doctors simply prescribe it off-label using current clinical consensus.
The bureaucracy is literally causing patient panic. And it's not just the volume either, it's the schedule too, because the sources point out Premarin, which is a conjugated equine estrogen cream.
Right, a different type of estrogen.
Its official FDA label recommends a cyclic loading schedule of 21 days on and then 7 days completely off.
Which is another holdover, but this time from systemic hormone replacement therapy.
Like the pills you swallow.
Yeah. When you take systemic estrogen pills, doctors sometimes have patients cycle off for a week to mimic natural menstrual fluctuations and to protect the uterine lining.
But we just established this is localized.
Exactly. For strictly localized, low-dose vaginal estrogen, Taking a 7-day break after a loading phase is totally counterproductive.
Because the tissue is healed and systemic absorption is basically zero anyway.
Right. Taking a week off just allows those freshly rebuilt tissues to start starving and regressing again.
So the doctor will tell the patient to ignore the 21-day cycle on the box and just do the standard 2-week daily load followed by twice a week.
Yes.
It really requires a lot of trust in your doctor to ignore the bold warning label on your medication.
It does. And, the rule of two is heavily dependent on the specific type of estrogen, too.
Right.
We've been discussing estradiol and conjugated estrogen so far.
Right.
But the NHS guidelines bring up a totally different category, estriol.
Oh, yes. Products like Ovestin 0.1% cream, Guinness 0.01% cream, and those Invagis 30 microgram pessaries.
Right. Estriol is a much weaker form of estrogen compared to estradiol. It binds to the receptors for a shorter period of time.
So it doesn't work as fast.
Exactly.
Oh.
Because the hormone is fundamentally weaker, you simply cannot achieve the necessary cellular rebuilding with just a 2-week loading phase.
So the rule of two is out.
It's out. The NHS specifies that estriol products require a much longer 3 to 4 week loading dose applied every single night before the patient can safely step down to a twice-a-week maintenance schedule.
4 weeks every night. That is a serious commitment. You have to be incredibly consistent for nearly a month.
You really do.
Which begs the question, what if a patient just can't do that? What if, a patient is dealing with cognitive decline and simply cannot remember a daily schedule for 4 weeks?
Or physical limitations,
Yeah.
right?
What if they have severe arthritis, making the physical dexterity required to insert a tiny tablet or a cream applicator every single night just completely impossible?
That is a very real clinical hurdle, and it's where the standard loading protocols fail completely. But for those patients, the estring becomes a vital tool.
Okay, I saw this in the sources. The estring is an estradiol vaginal ring, right?
Yes. And it is a massive exception to all these rules because it bypasses the loading phase entirely.
Wait, how does it do that? If the tissue needs a flood, how do you skip the flood?
So it's a flexible ring infused with a reservoir of estradiol. A healthcare provider, or even the patient themselves, inserts it into the upper third of the vaginal vault.
Okay.
And instead of a messy daily cream or trying to remember a daily pill, the ring just releases a microscopic, steady, continuous dose of 7.5 micrograms of estradiol every single day.
So there is absolutely no loading schedule to remember at all.
None. It is left in place for 90 days of continuous 247 localized dosing.
3 whole months.
3 months.
Yeah.
After 90 days, you take it out and put a new one in. It provides the initial flood and the ongoing maintenance seamlessly.
That is brilliant.
It really is. It makes it an incredibly elegant mechanical solution for compliance or dexterity issues.
It sounds like magic. Even the estring or the tablets or the creams, they all operate on one massive fundamental assumption.
Which is?
That the patient can physically and comfortably insert the medication into the vagina in the first place.
Yes, that is true. And when we talk about severe genitourinary syndrome of menopause, that is a very dangerous assumption to make.
Right. So let's talk about the extreme cases. What happens when the atrophy is so profound that standard loading isn't just uncomfortable, it is physically impossible?
In cases of profound, untreated GSM, the introitus, which is the physical opening of the vagina, can shrink, narrow, and lose so much elasticity that attempting to insert a plastic applicator or even a flexible ring causes excruciating pain.
Oh my gosh.
Or tissue tearing, or sometimes it is just completely blocked by the anatomy. The tissue can become almost completely fused.
I found a detail in the Pfizer Premarin prescribing information that totally blew my mind regarding this exact scenario.
The conditioning protocol.
Yes. They outline a conditioning protocol. For patients where local insertion is completely blocked, the sources state that the mucosa should first be conditioned with a short course of oral estrogen therapy.
Right.
Taking a pill to treat a localized physical blockage. I need you to explain the mechanism here, because how does an oral pill swallowed into the stomach help an applicator fit into the vagina?
It is a brilliant biological workaround. The protocol recommends taking 1.25 milligrams of oral estrogen daily for approximately 10 days.
Okay, so just for a short window.
Right. And it works via systemic blood flow. When you swallow that pill, the estrogen is absorbed through the gut, passes through the liver, and enters the systemic bloodstream.
So it goes everywhere.
Exactly. That estrogen-rich blood is then pumped throughout the whole body, including down into the pelvic capillaries. So it literally begins feeding and hydrating the atrophic vaginal tissue from the inside out.
Oh, wow. So it's attacking the starvation from the internal blood supply.
Precisely. Over those 10 days, That internal feeding thickens the mucosal lining and provides just enough structural elasticity so that the patient can finally tolerate the physical insertion of the local vaginal cream or tablet.
That is incredible.
Yeah, and once they can physically insert the local therapy and
Ugh.
begin the true loading phase, the oral systemic dose is discontinued. It's purely a biological jumpstart.
But okay, what if oral estrogen is contraindicated for that patient? Like maybe they have a history of blood clots or breast cancer and they absolutely cannot take systemic hormones.
That happens quite a bit, yes.
Or what if the inability to insert the medication isn't just about the tissue fusing, but is tied to like a psychological and physical trauma response after years of dyspareunia, painful sex?
That brings up a critical piece of the puzzle, which is vaginismus. When a woman has experienced severe pain with penetration for years due to atrophy, the pelvic floor muscles learn to instinctively spasm and clench shut.
Like a protective pain response?
Exactly. It's involuntary. And you cannot just force an applicator through a muscle spasm.
No, of course not.
So treating severe GSM in these cases requires an approach that is both chemical and mechanical.
Right. And the sources outline a protocol for this that sounds intense but necessary. If you can't get the estrogen inside, the clinical guidelines suggest utilizing the daily vaginal estrogen cream specifically because it can be applied externally.
Correct. You just throw the applicator away.
The patient is instructed to apply the cream topically to the outer vulva and the very outer edges of the introitus every single day for 4 to 6 weeks, just letting it slowly soak in from the outside.
Yes. The tissue slowly begins to absorb the hormone, gradually rebuilding the cellular layers at the entrance. But the chemical cream alone won't stop the muscle spasms or stretch the narrowed tissue.
Right, the muscles are still guarding.
Exactly. That's where the mechanical rehabilitation comes in. The sources highly recommend pairing this external loading phase with graduated vaginal dilators and pelvic floor physical therapy.
Yeah, the sources mentioned a specific device called the Millie, which I thought was fascinating.
Oh, the Millie is a fantastic piece of technology. It is a patient-controlled dilator.
How is it different from normal ones?
Well, traditional dilators are a set of static, smooth cylinders of increasing sizes. You have to swap them out. But the Millie is a single device that expands radially outward, just 1 millimeter at a time, and it's completely controlled by the patient pushing a button.
Which puts the power back in the patient's hands. That has to massively reduce the psychological fear and the muscle guarding.
It makes a huge difference.
So, you have the estrogen cream chemically rebuilding the cellular wall, making the tissue more pliable, while the dilator is mechanically stretching the room back to a functional capacity.
That is a perfect way to conceptualize it.
Yeah.
You're chemically rebuilding the wall while mechanically stretching the room. It's a slow, dual-pronged loading phase.
But all of this requires an incredible amount of patience and endurance from the patient.
Oh, absolutely.
I want to bring in that Reddit source we analyzed because the gap between this clinical science and the actual patient experience is staggering. There was a user who posted a really desperate question. She literally just asked, "Pardon, what is loading?"
That breaks my heart, but it is incredibly common.
Yeah. She said her primary care doctor had just handed her a prescription for estrogen cream, was super dismissive, and gave zero instructions on how to actually start taking it.
And of course, she was terrified.
Exactly, because the intense burning atrophy had started, and she didn't understand the schedule on the box, which, as we established earlier, was probably wrong anyway. How does a doctor write a prescription for something this complex and just walk out of the room?
It is a massive failure in clinical communication. Doctors often underestimate the sheer physical discomfort and confusion the patient is experiencing. And when they fail to establish expectations and timelines on day one, patients abandon the therapy entirely.
Right. And in that same Reddit thread, another user tried to offer support, but it highlighted another issue. They noted that they had followed the loading instructions, used the cream for 1 week, and were thrilled because the terrible vulvar itching had stopped.
That's a good first step.
It is, but they said they felt like maybe it wasn't working fast enough because intercourse was still absolutely agonizing.
And this is exactly why we need to lay out the biological timeline for people. Patients need to know that relief is staggered. Yes, the intense superficial itching and dryness might subside in just 7 to 10 days of the daily loading dose. But true, deep structural healing takes significantly longer.
Right, it's not a painkiller. You don't take a pill and feel fine an hour later.
Not at all. The clinical data confirms it takes a full 4 to 6 weeks of consistent use to notice meaningful improvement in tissue elasticity and actual pain reduction during penetration.
Wait, 4 to 6 weeks.
Yes,
But notice that 4 to 6 weeks is well past the standard 2-week loading phase.
exactly. The patient is already on their twice-a-week maintenance dose before they feel that deep structural relief.
Well, that requires so much faith in the process, to keep applying a messy cream for a month before the pain really stops.
It does. And honestly, the timeline extends even further. Based on the 12-week placebo-controlled trials in our sources, maximum clinical benefit doesn't happen until a full 3 months of continuous therapy.
3 months.
Yeah, it takes 12 weeks for the vaginal pH to fully lower back into that protective 3.5 to 5.0 range, and for the cellular swabs to show a maximum increase in healthy, plump, superficial cells.
So just to recap the timeline, 1 week to stop the itch, a month and a half to stop the pain, and a full 3 months to reach peak physiological health.
Precisely. And there's one final critical reality check that both the NHS and the American Urological Association guidelines emphasize.
And what's that?
Local estrogen is not a cure.
It's a management therapy.
Exactly. The underlying cause of genitourinary syndrome of menopause is the postmenopausal lack of endogenous systemic estrogen. The ovaries are no longer making it. Therefore, this local therapy must be used indefinitely.
Right, you don't just hit pause. If you stop your twice-a-week maintenance dose, you hit rewind.
Sadly, yes.
If you starve, the severe atrophy will inevitably return. The tissue will thin out again, the rugae will flatten, the pH will rise, and those urinary tract infections will just come rushing back. It is a permanent addition to your routine.
Which really underscores how important it is to find a specific formulation and a loading protocol that actually fits your life, whether that's a tablet, a cream, or a 90-day ring.
Right. So let's pull all this together for you. The loading dose is essentially a biological rescue mission for starved tissue.
That's a great way to put it.
And the standard clinical consensus for most estradiol products is a 2-week daily load, followed by twice-a-week maintenance, regardless of what the outdated FDA label on the box says.
Correct.
If you are using weaker estriol, you're looking at a 3 to 4 week daily load. The 90-day estring skips loading entirely. And if the atrophy is so severe that insertion is impossible, a 10-day oral jumpstart or a combination of external cream and graduated physical therapy with dilators can gently restore the anatomy over a month or more.
You've synthesized the mechanics perfectly. And I want to leave everyone listening with a final thought to mull over.
Go for it.
We've talked a lot about the medical bureaucracy and the frustration of these protocols. But if you look closely at the biology, this treatment is profoundly elegant. Think about how the human body essentially acts as its own dose regulator during this process.
You mean the cellular shield we talked about earlier?
Yes. When the tissue is starving and fragile, it is desperate for intervention.
Yeah.
It absorbs the hormone rapidly, taking exactly what it needs to survive and triggering rapid cellular division.
Right.
But as the vaginal mucosa heals, as it fortifies itself and builds up those thick layers of superficial cells, it naturally constructs a physical barrier. That barrier isolates the underlying blood vessels and actively prevents excess estrogen from entering the systemic bloodstream.
It self-regulates.
Completely. It is one of the rare, remarkable instances in medicine where the actual healing of the symptom autonomously controls the absorption of the drug.
Right.
The healthier your tissue gets, the more perfectly the dose stays exactly where it is needed.
The body literally builds its own dam to control the medicine.
Exactly.
It really is its own best pharmacist once you finally give it the right tools. Well, keep learning, keep asking questions when the label doesn't make sense, and keep exploring the incredible mechanics of your own health.